On behalf of NICU Medical Incorporated and the Neonatal Care Academy, it's my pleasure to welcome everyone to today's event entitled Neuromonitoring in the NICU. I'm Judy Moore. I'm the Director of Medical Education and Training at NICU Medical Incorporated, and I'll be moderating today's e-seminar. We will be recording the e-seminar today, and it will be available for viewing on the Neonatal Care Academy website in just a few days. In addition, at the end of this seminar, there will be a question and answer forum. So please type your questions into the Q&A box on your WebEx screen, and I'll moderate these for our presenter at the end of the session. So it is my pleasure and big privilege to welcome the presenter of our e-seminar today, Dr. Katrin Klebermash-Shrihov. Katrin is currently working as an associate professor in the Department of Pediatrics and Adolescent Medicine within the Division of Neonatology, Intensive Care, Medicine and Neuropediatrics at the Medical University of Vienna, Austria. Katrin's been actively teaching neonatal neurology at the bedside since about 2007 and has provided many lectures and workshops internationally on aEEG in the neonatal intensive care unit, on aEEG in preterms, on neuromonitoring in neonatal intensive care, and also on LISA, the less invasive surfactant administration technique. Her main research focus is to understand newborn brain development and neurological injury of preterm and term-born infants, with a special interest in early brain maturation, both physiological and pathological, of preterm infants. Her research work also extends to establishing reference values for different electrophysiological methods and for different maturational ages in preterm and newborn infants. So neuromonitoring within neonatal intensive care and early detection of brain injury within this preterm group is very important to her practice in order to analyse the ontogeneity of sleep in newborns as an early sign of brain integrity. So with no further ado, I would like to hand over to Katrin for today's presentation. Katrin, it's over to you. Thank you.
Thank you, Judy, for this nice presentation. I will really welcome everybody to this e-seminar. It's a big privilege to talk to you here about neuromonitoring in the NICU. You heard it's really a hard project of me. So I hope we will have fun during this next hour, and I'm really looking forward to your questions, and hopefully you will enjoy this hour as much as I will do. When we look to our intensive care units, actually we are already monitoring a lot. But I always wondered why, especially when neurological impairment is one of our major concerns in our treated infants, that it's not clinical routine to assess cerebral function. I think it is very important to know what is happening in the heads or in the brains of our patients. So actually the heads of our patients should look like this. There is space enough for adding electrode and adding monitoring devices. But what is the role of neuromonitoring in the NICU? Actually, we want to make sure that the brain of our patients is working normally. If the infant has suffered some brain injury, how bad is it? If there is some injury, and how is the brain adapting to illness? And very important is to know, is there further evaluation needed? And even more important is to know, is there further therapy or intervention needed? So looking to neuromonitoring, there are different options. So actually, we can, of course, do clinical examination, which is basically always difficult in intensive care patients, especially if they are very preterm. We can do ultrasound. This is something we can really do easily at the bedside. We can use EEG, aEEG, or evoked potentials, so neurophysiological methods. We can use near-infrared spectroscopy, and we can use magnetic resonance imaging. So actually, it's important to know that the first four we can really use directly at the bedside. And aEEG and NIRS especially we can use as a continuous monitoring. Ultrasound and MRI are morphological methods, so actually they are giving us a picture of the brain, whereas the other three are functional methods, and it's always nice to combine these things to really see the full picture. What we mainly use in daily life is clinical examination of our babies or ultrasound. I think this is really routine nearly everywhere. MRI is increasingly coming also as a neuromonitoring tool, and it's really fancy nowadays with diffusion tensor imaging, spectroscopy, and things like that, so we can really can get nice pictures of the brain. But you know, it's always connected with transport. Nearly nobody has really the possibility of having an MRI on the ward, although this is maybe coming in the future. The gold standard in neurophysiology is conventional EEG, including a video. And you see there is more channels, there's 10 seconds per page, so it's a very detailed and good neurophysiological method. But of course, we need a lot of electrodes, which is a problem in the preterm babies. And actually, when we look to neuromonitoring, how should it be? It should be easy. It should be easy to use. It should be easy to interpret. Most happy we would be when we could interpret it directly at the bedside, and when it could be interpreted by ourselves, the NICU staff. So also helpful would be when we don't only have one look at one moment, but to really see the long-term approach or the long-time surveillance of disease or any problem. So long-term monitoring would be interesting. And the Latin word monitor means warning. So we want to be warned on a long time way if there's anything changing in the heads of our patients. So trend monitoring during clinical critical periods, that's what neuromonitoring should be in the intensive care unit. Of course, it would be nice to have a prediction of outcome, so to really sort out very early on in the course high-risk infants. And of course, it would be really nice to improve long-term outcome of these infants. But these two things are not so sure. We will talk about this later on. So what options, what methods do we have for neuromonitoring in the NICU? First of all, as I already said, we have many options, and it's always nice to not only look on one spot. If you have more spots, you can see you have a better picture of the whole things, because sometimes you're only looking on the top of the iceberg. Starting with amplitude-integrated EEG, maybe the most used neuromonitoring tool in NICUs nowadays. It's a simplified EEG monitor. It's a time-compressed trace. Usually it's only 1 or 2 channels. It's a special filtering, which makes it easy also to use in intensive care environment. And long-term monitoring seems feasible with this method. And there is a good correlation with conventional EEG, or at least good enough with 80 to 100% correlation. So to see abnormal background activity should be possible in 100% of cases. How could we classify aEEG? Actually, we can use a pattern classification. We can see a small band, which is called continuous pattern, or a more broad band, which is then discontinuous. And if the amplitude is lower and lower, we have abnormal or depressed traces like burst suppression, low voltage, and flat trace. And there's also the possibility of using the voltage classification, where you just look at the margins of the amplitudes, if it's above or below the 10 microvolts. So actually, it's very easy to see, even for a beginner, the difference between the pattern above, the continuous normal voltage pattern, which would be normal in a term baby, and the very flat suppressed EEG activity, which is never normal, even not in a very, very preterm baby. And another advantage of aEEG is that it's really easy to apply. You only need 3 or 5 electrodes. So this should be also possible in preterm infants when they are using respiratory support and these caps for it. Long-time recording, as we can see, it's a time-compressed trace. It's really possible, and here you can see the evaluation of a depressed amplitude to a really normal amplitude trace over time. So you can see what's really going on and how quickly this infant was getting better. So we can see 3 hours at one glance, looking at one screenshot. And still, it's a lot of data, and especially when we look to conventional EEG, there is 10 seconds per page. So actually, it's pretty much data. Even if it's digital nowadays, it's really, really time-consuming to looking at these data. So we need some simplified, compressed version. And actually, we should have a simplified version available for us directly at the bedside, at the intensive care unit, available 24/7 if possible, which is less detailed and show no regional differentiation, which we could see in the multi-channel and more detailed conventional EEG, of course. So we actually need both. We need the combination. We should add conventional EEG for final diagnosis, but for long-term monitoring and as a surveillance tool, aEEG is fine enough. And actually, I think we do pretty much the same with EKG, because we have a simplified version continuously using in the intensive care unit. But if there's a problem, of course, we need further investigation by a more detailed method. So aEEG, especially when it's helpful, in which situations can it help us to care for infants and newborns in the NICU, especially after asphyxia, perinatal asphyxia, or infants with HIE, in infants with neonatal seizures, congenital heart diseases, inborn errors of metabolism, preterm infants, and maybe also in daily routine. So we will talk about all this. We know that changes in EEG and also aEEG background are powerful, but on specific markers. Usually in an acute stage abnormality, EEG is flattening, there is an amplitude depression, there is seizure activity ongoing, and if there is some chronic stage abnormality, usually you are having some maturational delay or dysmaturity or some loss of sleep-wake cycling. So you can maybe even time an injury. We don't know what is behind it, but we see that there is a problem. The next option we have, and it's also increasingly used nowadays, and it's also nice because it's easy and continuously possible, is near-infrared spectroscopy. It's a continuous, real-time, non-invasive bedside monitor of regional tissue oxygenation. It's validated with jugular venous saturations, and it can also be used in infants. Actually, it's a mixture of arterial and venous blood saturations. And actually, it's just more than showing us if oxygen is delivered right now, because it's also dependent on cardiac output, on blood pressure, on hemoglobin concentration, and also ventilatory status. So it just adds additional information to this. We know for newborns that there is a safe zone when this regional tissue oxygenation is above 55. We are on the safe zone. Then there is an intermediate zone, and below 45 there is danger zone because it's too low. So actually, we should not only react in increasing our oxygen, because we should also, as I said, to hypotension, to red blood cell count, and maybe also to cardiac output, CO2, and things like that. So it's more than just increasing oxygen. Who may benefit from NIRS monitoring? Preterm infants, infants with PDA, also hypoxic ischemic encephalopathy babies, infants with intraventricular hemorrhage, especially infants with congenital heart disease, as this regional saturation is correlated to cardiac output, or any critical ill infants with hemodynamic instability on the intensive care unit. So that's why nowadays it's really increasingly used. Another form of neurophysiology, we had conventional EEG, aEEG, it's evoked potentials, and it's also quite easy to use, and it's a single response of a single system, so we can assess functionality in a certain anatomic pathway. Mainly it's used visual evoked potentials, and it's interesting that the visual pathway is next to the ventricles in newborns or in everybody, but that's why it helps in IVH or hydrocephalic babies. And of course, somatosensory evoked potentials are helpful to assess maybe injury to cortical spinal tract, which is also interesting, which cannot really be seen clinically in the newborn. So there are many indications and so little time and so many methods. So what should we really use to see the full picture? Actually, we should definitely combine methods to see the full picture, to have different spots we look at. So we now try to talk about different patients groups. So here the perinatal asphyxia, hypoxic ischemic encephalopathy baby. So what are the best prognostic markers for these infants? Actually, it's the aEEG combined with clinical examinations would have the best prognostic assessments. And actually with aEEG, we know the earlier abnormalities disappear, the better the neurological outcome will be. So in a hypothermia baby, when there is normalization of the background activity within 48 hours, we can really be happy. So here you can see the sensitivity and specificity of aEEG in HIE babies is approximately 80 to 100%, but these are data before hypothermia was routine. But we can see in another meta-analysis that especially at 48 hours there is a very high specificity and a still high enough sensitivity for this method. So infants with good outcome should have normalized background after 48 hours when they are treated with hypothermia. The cyclicity, when you see aEEG traces, you see sinusoidal changes in EEG activity, which reflects not really sleep-wake, what we called it sleep-wake cycling up to now, but usually nowadays we call it cyclicity because there is some states changing, but we are not sure. It's not always wakefulness and sleep, but we know that it's only produced by a healthy brain, so it's always a very good sign. That's important. So every healthy baby, even when it's 23 weeks, and very preterm, should show this. So also in the HIE babies, the earlier the cyclicity appears, the better the prognosis. And if you now add or do your monitoring with NIRS, for example, you see that the tissue oxygenation is also a good marker for outcome in HIE babies. And interestingly, the TOI was higher in infants with abnormal outcome. And if you think about it, it makes sense because it just means that we are good in getting oxygen in these babies. We also distribute oxygen to the brain, but the brain is not using it. So we will find too high regional oxygenation. Actually, this is data of our own research group, and which showed that when you combine aEEG and NIRS in HIE babies, you have a better specificity. And as always, looking from more than one side is improving your view. MRI, of course, is also important in HIE babies. You can have two lesion pattern. You can have a deep gray meta lesion, mainly in the basal ganglia or the thalami, and you can have some watershed injury in the cortex, maybe frontal or parietal. And MRI usually is used later on in the course. So early MRI would be around day 3 or 4, and late is usually around day 8 or 10, 11, something like this. And you see that's very high sensitivity, very high specificity, so it's a very good method. But as we said before, it's difficult to transport a very intensive cared baby to MRI if it's not really on the ward. So for prognostic tests in HIE babies, you see that aEEG and even early aEEG is really, really helpful. MRI is the second best, and then you see that ultrasound and visual or somatosensoric evoked potentials are also helpful. So combination of methods would help. So in HIE babies, we should use all of our 5 neuromonitoring tools. Clinics is very helpful, aEEG is very helpful, and MRI is very helpful. But you see also ultrasound and NIRS can add additional value. Coming to babies with neonatal seizures, this is also a difficult topic. We know that especially in newborns, seizures are relatively common, and we know that it's difficult to detect and difficult to treat, or maybe even harmful to the brain. But we don't know if it's still true that it's difficult to detect when we use continuous monitoring, or even more continuous than we did before. And actually, this harmfulness to the brain can be assessed much better when we have an exact seizure burden. And seizure burden means that we know the exact time of seizure activity in minutes over 24 hours or per hour or whatever. So what exactly is a seizure? Actually, the classification needs to be rethinked, because electrographic seizure activity and clinical seizure activity was nearly not very easily recognized. So clinical signs are not very easily recognized of electrographic seizures, and there are, we all know, many infants showing motor phenomena which looks like seizures, but they have no EEG correlate. So actually, when we only use clinical assessment, we might even overtreat infants. So historically, when we based our seizure diagnosis to clinics, we maybe exposed infants to unnecessary medications. And there are a lot of seizures now that we use more and more continuous monitoring, that there is electrographic seizure activity without any clinical signs. So there might be undertreatment. So we have to really redefine, and there's a new classification for neonatal seizures upcoming, that you really have suspicion of seizures, and actually the EEG, the aEEG, the conventional EEG should make the diagnosis. So only electrographic activity really diagnoses your seizure, and then you can see if it's with or without clinical signs. And actually the implementation of such a program in term newborns, at least for everyone who's now worried that we treat more and more even when we use electrographic seizures only. No, actually treatment was even reduced because it was much more targeted and it was much more special. And as I said before, when we use only clinical seizure assessment, we really tend to overtreat infants, or maybe treat them for a too long time, because we know actually in the acute phase there's a lot of seizures ongoing and then it stops, so we don't maybe need long-time treatment. So it makes it much more targeted with the continuous monitoring. And we know that these seizure burdens, or really these minutes of cumulative time of seizure activity, this is correlated to outcome. So to reduce total seizure burden should really be an aim. But for that, we really have to assess it. And that means that we have to have more than only 30 minutes of a day of conventional EEG. So especially in the full-term infants, we know that maybe more than 70% of seizures are really clinically not easily seen. You see that most of the infants which seizures have it due to hypoxia and ischemia or stroke. And then there's hemorrhage, infection, cerebral malformations, metabolics, even inborn errors of metabolism. You see that really only a small number of infants suffer from so-called epilepsy. Most of neonatal seizures are secondary seizures, so they are a symptom of an underlying brain injury. In preterm infants, it's the same. We know that usually infants with cerebral injury show seizure activity, and they have even a higher rate of clinically silent seizures. So especially the first week of life, preterm infants are very prone for seizure activity, so continuous monitoring in this time period would make sense. But actually, if you look into more detail, you see that the median time point of reported seizure activity is 27 hours in full-term infants and 14 days in preterm newborns. Of course, seizures associated with IVH or parenchymal infarction will be shown in the first week of life, but hypoxia, ischemia, metabolic derangement, or infections can be also later in the course. So also here, continuous or even more detailed or more often aEEGs would help to really assess. So neuromonitoring in neonatal seizures should be mainly neurophysiological methods like aEEG, and of course for seizure diagnosis you need conventional EEG, but you can screen or really survey for a longer time with aEEG. NIRS is not so helpful in seizure babies, but MRI and ultrasound to look if there is any bleeding, any signs of malformations, infections, and of course clinical assessment will be helpful in these babies. In infants with congenital heart disease, brain injury is also common. So we know that approximately 1/3 of these babies show seizures during their intensive care course. And actually, really similar to the HIE babies, a prolonged recovery after cardiac surgery is associated with an increased mortality and morbidity in these infants. So failure to recover by 48 hours is significantly associated with later impairment. So it's really similar to the HIE babies. And aEEG is also correlated to outcome, to neurodevelopmental outcome, and to MRI findings. So here an example for an aEEG during heart surgery, and see, because these babies are really cooled down a lot, you see that the aEEG goes very flat. And during rewarming here, you see a sudden increase of the aEEG, which showing a seizure during rewarming, where the orange arrow shows. So this would help to identify how often this happens and how quick these infants are recovering. Especially NIRS is used a lot in congenital cardiac malformation babies because it's correlated to cardiac output and to jugular vein saturation and supravena cava flow. So it's a kind of non-invasive hemodynamic monitoring. So the anesthetists during these surgeries can use NIRS, you can use Doppler, or even automated EEG like this, for example. And this might potentially improve neurological outcome, because you better know how's the brain doing during these very, very difficult surgeries. There is no proof yet that this really is improved outcome, but everyone will tell you it's so much easier to see what is going on in the brain of the infants. So for congenital heart disease babies, we can also use clinical assessment, but during surgery it's really difficult. Ultrasound is still helpful. aEEG and especially NIRS are helpful with continuous monitoring in the critical period. And MRI also later in the course could add some value. So inborn errors of metabolism, not very high number of infants, but if it's there, they are usually very sick. Sexually, we know that there is usually an abnormal background, so they might be identified earlier. They have a very high incidence of seizure activity. So it's not diagnostic aEEG, for example, or neuromonitoring itself, but it can assist in assessing the severity, and it can lead to treatment maybe. Coming to a very increasing number of high-risk infants, the preterm infants. I think everyone would agree that a preterm, very small preterm of 23, 24 weeks is on very high risk for neurological impairment. It's so difficult to monitor preterm babies because it's so difficult to distinguish what is normal, because being outside the womb of your mom at 24 weeks is pretty abnormal already. So we don't know what is normal. And additionally, it's changing quickly because maturation really is very, very fast, especially in these preterm periods. I mean, the brain is not changing so much from term to the adult as it is from the preterm to the term age. So this is the time point where really a lot is happening. So we can see some changes, pretty normal at some ages, but very abnormal when it's present later on. The dominating background activity in preterm infants is discontinuous, because the younger they are, the more discontinuous the traces are. Maturation goes from discontinuous to continuous pattern. This makes pathology, and we heard about that the acute stage abnormality is showing increasing discontinuity, makes it more difficult to detect, but it makes it not impossible. Especially in preterm infants with brain injury, IVH, PVL, strokes, and things like that, monitoring is really helpful. But it's also more than this, because it is correlated to neurodevelopmental outcome. And these, again, are data from our own research group. and of infants who had a normal outcome. So we analyzed preterm infants below 28 weeks in the first 2 weeks of life. And the ones who developed normally after 3 years, 93% had a normal aEEG trace in the first 2 weeks of life, and 98% showed cyclicity, or the sleep-wake cycling we talked already about. And the infants with impaired outcome, only 18% showed normal aEEG in the first 2 weeks of life. So you can identify infants for high risk very early on in the course. And if you look to sensitivity and specificity of aEEG for these babies, it was best in the second week of life. First week, there's a lot of maybe medications ongoing, critical, ill infants, more hemodynamic problems. So usually in the second week, there is the best prognostic value. And actually it was better than ultrasound. And we all counsel parents, or we make our risk identification due to ultrasound or morphological pictures. So to adding a functional method here would be increase our sensitivity. So actually also your infrared spectroscopy can maybe add. Here you see that these infants with adverse outcome had significantly lower tissue oxygenation values. So also here monitoring would help. And there was an interesting multi-center trial designed, the Safe Boost trial, where there was continuous monitoring with NIRS in the first 72 hours in preterm babies below 28 weeks. And in one group, there was interventions done, like looking on CO2, looking on blood pressure, increasing your hematocrit, increasing your oxygen, whatever, to reduce hyperoxia and hypoxia. And in the other group, it was monitored, but it was not seen, so it was a control group. And actually, you see that in the intervention group, the burden of hypoxia and hypoxia could be significantly reduced. So there was great hope that this will also influence neurodevelopmental later on. So it would have been the first study really showing the benefit of early neuromonitoring. But there was no difference in the neurodevelopmental outcome after 2 years, although there is a trend to higher MDIs in the intervention group. So maybe we need to repeat this in bigger groups and really not stop doing this, and although there is no proof yet that it really improves long-term outcome. Another patient group within the preterm group, which is really interesting, is infants with post-hemorrhagic ventricular dilatation. That's a dynamic change. And we usually measure ventricles, so we only look to morphology. But we know that some babies show clinical signs early in the course. Some really tolerate quite widening of the ventricles. So we tried to add monitoring of brain function in these infants. And actually, we could see here an example, and we saw that in many infants so far, that you had a quite normal trace. It was a 24-weeker on day 3, and within the course, the baby developed IVH grade 3 and post-hemorrhagic ventricular dilatation, and you see that there's a significant decrease in amplitude. There's a loss of cyclicity in these infants, and with pressure-relieving intervention, in our cases we do ventricular drains, the activity came back. And actually, this is very interesting. So we think maybe more individually targeted therapy would help to really help us in what is the optimal time point for intervention, which is a big discussion. Should we early intervene? Should we late intervene? And actually, we also added in a couple of patients NIRS to this. And we could see in every infant there was a lower NIRS value before this decompressing intervention was done. So you can see with monitoring in which infants which ventricular size is the critical one, or which intracranial pressure is the critical one, because it might be not the same for everybody. So neuromonitoring in IVH babies, in infants with ventricular dilatation, they're especially helpful is besides ultrasound, of course, aEEG and also NIRS and MRI on the long run. In the extremely preterm infants, as a routine, I would say to see maturational changes in aEEG and combine this with ultrasound, it's also very helpful. And MRI, some of us do MRI in preterm infants routinely at term equivalent, for example. It's also helpful to really identify high-risk infants. So neuromonitoring and daily routine, are we already there? Actually, now we talk about things which makes it more difficult, neuromonitoring, because medication is influencing it. We have, for example, caffeine, which is increasing activity. We have all the sedatives, analgetics, which are suppressing our activity, our EEG activity. Blood pressure, we already heard about that. Here you see an example of a baby with a high CO2, and you see that this is maybe due to reducing cerebral perfusion, but it's reducing cerebral activity, sepsis, acidosis, glucose levels, CO2, and much more. So for daily routine, it's really, really important to have more additional multimodal monitoring. And for the critical phase, it might be helpful, but you have to have all this in your heads when you're looking at pictures. Here, for example, NIRS data with showing hypocarbia during mechanical ventilation, and when the PO2 was rising, the PCO2 is rising, perfusion improves, and the tissue oxygenation rises in a preterm infant. And here you see aEEG data of a 36-week-old infant with a hydrocephalus, which was clinical stable, spontaneously breathing, and there is this sudden drop in aEEG. And when we walked by, we said, hey, someone added some medication, what's happened here? And then this baby got apnea. So actually we saw that there was a drop in blood pressure, which was not really bad. But for a baby with an increased intracranial pressure to hydrocephalus, brain perfusion was not enough. So maybe our blood pressure limits are maybe more individual than we think, and maybe also dependent on injuries. So for hypotension in preterm infants, NIRS, for example, can be used as a surrogate for cerebral blood flow. So it might be interesting to see if there's a low blood pressure and the baby looks fine, and we all know these patients, and we have babies which have quite normal blood pressure values, but they still have a problem. So we know that it's more individual. So adding brain monitoring also in hypotension treatment would make a lot of sense. But there's really a lot ongoing. We know nowadays that brain maturation is dependent on environment. So actually the brains of infants cared in a single room looks different than in a big room. So actually also aEEG looks different in the open ward or in the private room. And actually there is concern that there was a reduced language development in infants in these private rooms. I mean, it's very important to reduce all these stimuli you see in these open wards, because there's a lot of noise, a lot of light, a lot of stress added. But maybe in the private room there is not enough, maybe for the maturation, especially in infants where moms are not close or even there for 24 hours. So there are now ongoing therapies, for example, and also here neuromonitoring can help, because you see there's an influence of, for example, music therapy on maturation of cyclicity or aEEG scoring, which is also interesting. So if there is intervention done, you can maybe check with neuromonitoring if there's anything changing. So these are really new approaches. Here, for example, data of NIRS and PDA treatment. You see that aEEG and NIRS are influenced by PDA surgery. So to sum all this up, where are we standing with neuromonitoring in the NICU? So actually, it's useful. There are different methods, and you see there are different possibilities: seizures, HIE, IVH, intracranial bleeding, congenital heart disease, preterm infants, strokes, which could be also added to the hypoxic ischemic way, infection, encephalitis, meningitis, malformations, or metabolic disease. And you see especially aEEG is really helpful in all of this. Ultrasound is helpful, MRI is helpful, but in some babies adding NIRS or looking more repetitive on also clinical examination would add and would complete the picture. But there are also a lot of things influencing all this, as we already heard. So we can never be sure if we see really only the effect of these injuries. And we are not always sure what to do with the result if there is a change in neuromonitoring. But it gives us a picture and a trend. And remember what we wanted from neuromonitoring at the beginning. We wanted to have a trend, a warning, a surveillance tool. And still there's no proof that neuromonitoring can really improve outcome. We are all believing it, but maybe we are only at the beginning. We have to learn what is normal and think about how our perception of seizures have changed over time with these neuromonitoring tools. So we can maybe even better target our therapies. We can better survey our therapies. So we can definitely nowadays already identify our high-risk infants. And this, I'm pretty sure, will on the long run improve the care for these infants and also the outcome, but it's not proven yet. So for me, the outlook is to combine morphology to function, because when you look to a picture of a dilated ventricle system, which is not so bad in this infant, if you have an aEEG like this, where you see continuous activity and discontinuous activity and you see cyclicity, you can be maybe pretty happy. But if there's a picture like this, where there's no cyclicity and it's only discontinuous, it's not normal maybe for the age group. So you should be worried at least. And if you see such a picture with a status epilepticus or a very depressed amplitude, you should be really worried and you might to do something immediately. So combining these methods might really change our therapeutic strategies. And if we add more than one method, this will really also improve our perception of the problem. And for the future, because we want to talk about outlook here, automatic analysis of these methods and automatic combination is what all groups are working on right now. So for the future, it should be getting even more easy to use right at the bedside as a monitoring tool. So thank you very much for your attention, and I'm really looking forward to any questions.
Catherine, thank you so much for a very informative lecture. We already do have several questions that have been posted in the Q&A box, and there's likely more to come. So if there's anybody online who would like to pose another question, then please do. But Catherine, I'll start with a few of these. So a recurrent question is, can we get the presentation? And I think the answer to that is, we have recorded this e-seminar, as I mentioned, and the recording will be posted to the Neonatal Care Academy website, so you'll be able to find all the information and references there. I have another question, which was, for basic monitoring with aEEG, how many electrodes or channels would you choose to use? Would you choose just the 3 electrodes and 1 channel, or would you choose out of preference to have the 5 electrodes and more channels?
Yeah, it's a good question. Thank you. And for only assessing background activity, 3 electrodes would be enough. But there are brain injuries not really diffuse in the whole of the brain. So if you at least have the suspicion that one side is maybe more injured, then it really helps to have this bihemispheric approach. And it's only 2 more electrodes. So actually it's easily done. But for pattern recognition, you should always use the cross cerebral, so only the 3 electrode approach, and you can switch in many machines between the bihemispheric and the cross cerebral. So for basic, it's enough to have only 3, better than nothing. But if you go into more detail, the bihemispheric might really help, because you then see, even when you go to MRI, on which side do I need to maybe look more in detail. So it's really helpful to have the bihemispheric approach. Also,
Thank
at least.
you. Excellent. So, and this is another electrode question. So which kind of electrodes would you use So would they be needles or cups or hydrogels? And would this differ between full-term and preterm infants?
Also a very good question. Thank you for that. Yes, it might differ. Actually, I personally, or we in our unit, we use gold cup electrodes for everybody because we are now using this for many, many years, and then everyone is quite experienced with it. We can reuse it, and it's easy also for the preterm and for the term baby. But especially in a term baby after HIE, it's really important to know what is going on in the brain. So for that, needle electrodes are very helpful. And especially if you want to do a 3 or 4 day continuous recording, it's really, really much easier with needle electrodes. But for a routine monitoring of a preterm baby, I wouldn't use needle electrodes so easily. So then it might be helpful to have 2 different kinds of electrodes, and also the new hydrogel electrodes are helpful, but also careful in the very preterm babies, maybe for the very immature skin. So it might be helpful to have more than one option of electrodes, yes.
Okay, thank you. Which brings me on nicely to another question about preterm babies, which is if the aEEG is most sensitive and specific in week 2 for preterm for prognostic value, how long would you monitor these infants for, and when would you stop monitoring?
Yes, thank you. It's really necessary maybe that I clarify, because the data I presented from our unit was a 4 to 6 hour recording once in the week. So we're not continuously monitoring the whole second week or the whole first week. It would be nice though, but it might be enough to have one punctual assessment. We talked about we don't like just to look only on 1 day or only on 1 hour, but it's better than nothing, and combination of morphology and function really adds value. So it might be enough to look on the day where you do routine ultrasound, and you're usually also repeating this in preterm infants every week or at least every second week, for example, and then add, for example, 4, 6, 8, 10, 12 hours, how long you can do it. aEEG, the longer the better, of course, but you don't need to do the full week of recording. So I would say between 4 to 6 hours minimum to 24, for example. This would help.
Excellent, thank you. I have another question about general monitoring, and that's what artifacts do you generally experience when using aEEG, and if you experience artifacts, how do you avoid them?
Yeah, also difficult questions. Artifacts are really a problem in intensive care units. So it really can be seen, first of all, looking at impedances, because most of the machines can really show you how good is your impedance of your electrodes. So this is one thing. So hair and maybe hematoma or stuff like that might be a problem. Then in HIE babies, these cooling mattresses are really a problem because there's fluid in it, and this is a problem. So many machines, electric dense environment is a problem. So you can try to separate your wires better, not to have a lot of cables connected or crossing your EEG traces. You can try to really not have contact of the electrode and the incubator, for example. So yes, it's tricky. And also ventilatory artifacts, so if there's high frequency ventilation, for example, when all the baby is shaking, this can really also be seen in the EEG trace. So many different things. Also placement of the electrodes can be a problem. If it's too close, you see a very low amplitude, because usually EEG and also aEEG is measuring the difference of 2 electrode activity, or so that the activity below 2 electrode areas. And if it's too close, then it's called a bridge, and then you see a low amplitude. So always make sure that when you see maybe asymmetry, or if you see depression, make sure that that nothing of this is the problem. So always be careful monitoring your electrode impedance, watch your electrodes, Also medication, of course, can be a problem. So if there's a very flat trace, try to cut down your sedation or analgesia. And then you might come to see changes and then really increase your monitoring period. And if it was the medication or if it was the electrode placement, if you change it and you see then a difference, it was not the brain of the infant. So always work on this.
Okay, that's excellent. Thank you. And I did post this back as an answer in the question box, but for anybody else who's interested in understanding more about artifacts, we do actually have a very nice course on the Neonatal Care Academy website specifically dedicated to identifying and eliminating artifacts out of the aEEG. So just visit the Neonatal Care Academy website and you'll find that. Okay, this is another question in regards to the length of monitoring. So I'm guessing that this is in relation to full-term babies, but if you have a continuous normal voltage trace, how long would you continue the aEEG monitoring for in a well baby?
If there's no cooling, for example, so it was just for the screening, we thought the baby is, we know there was a perinatal asphyxia, and thankfully there is everything fine clinically with the baby and everything fine with aEEG, you can stop. But if the baby is under hypothermia, I would definitely cover the full period of hypothermia, so the whole 3 days, and especially warming period, because we know that even in this period, seizures might appear quite likely. And you can maybe remove it in a healthy baby just to make sure that if there is some clinical changes or some suspicion, you can put it on again. So it's not necessary to monitor for hours or days a healthy baby, but if there is brain injury in other methods, it might be help to really assess maybe 24 hours to make sure that everything is really fine also in the functional method.
Okay, thank you very much. So this next question, I think we've got time just for a couple more. The next question is actually in relation to cerebral ultrasound. So I know I'm sure you might have an opinion on this. And the question is, what is your opinion about using resistive index in cerebral ultrasound for monitoring hemodynamics?
Yeah, it's an interesting method, and we know that we can use it also in bigger infants or even children. So yes, it's helpful. If you're good in this, it could add some value to this, because not only morphology, then ultrasound also turns into a functional method. So yes, if you have it, it's a good thing to use.
Excellent, thank you. And we'll make this one final question. So the question or statement, there's a lot of discussion that the infant's brain has extraordinary recovery and healing ability. How often do you see negative early diagnosis turn out with long-term effects that are not indicative that the infant suffered cerebral injury? Do you see that often?
Yeah, actually we all think and we all hope that newborn brains can really recover, and they can definitely better recover than our adult brains. But all these methods show so good correlation to outcome that I think there might be exceptions, but it's really not a general rule that there is surprise. We know that parents can make a big difference, and the educational status of the parents is one of the most important influence of neurodevelopmental outcome, especially in preterm babies. So yeah, there can be a lot of achievement done, but I've never seen severely abnormal neurological methods and then a pretty normal outcome. Maybe, you should never say never in medicine, but it's not very likely. But of course you could never see exactly the prognosis. You can only see this is high risk, this is medium risk, this is low risk, and there is some possibility, there's some range for infants, coming from genetics, coming for comorbidity, coming from parents, and for support, for example. So you never can be sure about your prognosis, and actually I would not tell parents that's what I expect. It's just, I would just classify these infants in high, moderate, low, and no risk, maybe. So usually it correlates better than we hope, maybe.
Okay, excellent, thank you. So thank you again, Katrin. It was such an informative lecture, such an informative question and answer session. I really appreciate your experience and your expertise. I'm actually just going to share here on the screen the Neonatal Care Academy website, because for anybody who's not looked at the website or isn't registered, there's a wealth of online courses. Here again, you'll find all of our recorded e-seminars, and this specific e-seminar will be posted to the website by next week. So do visit, it's www.neonatalcareacademy.com, and I'm sure you'll find a lot of useful information on there. So on that note, I'd like to thank everybody for joining. There will be a short survey that will pop up at the end of the WebEx for you if you kindly fill that in for our feedback, specifically with topics that you would like to see in future e-seminar recordings. So thank you, everybody, once again, and I wish you all a good day. Thank you.